about, but it's my body, breast cancer risk and decision making. So right now I'd like to bring to you Holly Pederson, MD. She's a staff physician and director of medical breast services in the Breast Center. She is an assistant professor at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. After receiving her BA in biochemistry from the University of California, Santa Barbara, where she received the distinction of the Phi Beta Kappa, Dr. Pederson earned her medical degree from the University of California, San Francisco School of Medicine, where she was recognized in the Alpha Omega Alpha Honors Society. She completed her internship and residency at the University of California, San Francisco Medical Center in Internal Medicine, and in 2008 completed a clinical fellowship in genomics at Cleveland Clinic. She directs the medical breast program and is active in clinical research. Please welcome Dr. Pederson.
Thank you. Going back to the short person version of this microphone. There we go. Thank you so much for having me here. Thank you, Dr. Eng, for your mentorship. And let's give a big round of applause to Kristen, Anthony, members of the board, and our great volunteers for this fun day. It's great to have everybody here together today. And I'm speaking with Dr. Karen Hurley, who's a psychologist, and that's not by accident. At Cleveland Clinic, we really recognize that having the risk for cancer, and particularly breast cancer in particular, is not only an issue of statistics and numbers, but also emotions and feelings around that risk. And we like to work together to not only process the numbers, but also process the feelings. So we'll be working together. So Dr. Eng has really taught us well that there are red flags for hereditary cancer. You know, the majority of cancers are what we call sporadic. They happen more by chance. They're an accumulation of insults to someone's DNA. But there are individuals who are predisposed to cancer, who really have a higher rate of cancer and an earlier onset of cancer. And they're so important to recognize, and we really believe that patients with PTEN Hamartoma tumor syndrome are under-recognized and hope to change that. You know, the average age of diagnosis for breast cancer is 62 in this country. And in patients who have hereditary syndromes, it's much younger. And so we're aiming to help to educate other providers to recognize this. And importantly, when a patient has hereditary cancer, we want to address the family. Are other family members at risk? What additional screenings can we embark on to reduce the risk of other cancers or to catch things early if they do occur? So Rachel Cowden was a young woman who was the first person recognized to have PTEN Hamartoma tumor syndrome in 1962. She presented with fibrocystic breast changes, that lumpy, bumpy change that we all have, a multinodular goiter, and oral papillomas. And later, unfortunately, died of metastatic breast cancer at the age of 33. And we hope to have those situations not occur because we now know so much more about disease and about screening. As Dr. Eng pointed out, there are a number of cancers that patients with PTEN have increased risk for. And the one that's at the top of the list is breast cancer. So if you look at the average lifetime risk of a person in the general population getting breast cancer, we all hear that number all the time. 1 in 8 women will get breast cancer at some time in their life. But if you look at a person with PTEN, not only is that risk so much higher, up to 85% lifetime risk, but the cancers occur much earlier. This is a picture of myself and my mom, and the risk of getting breast cancer with PTEN before the age of 50 is up to 50%. And over the course of one's lifetime, up to 85%. So it's not only a function of a higher lifetime risk, but an earlier onset. And it's so important to identify people early and start on early screening to reduce risk and catch things early. And as Dr. Eng mentioned as well, if someone does develop a breast cancer, there's a much higher risk to develop a second breast cancer. And in fact, it's about a 30% chance over the ensuing 10 years. So oftentimes when people are diagnosed with breast cancer, if they know they carry a genetic mutation that markedly increases risk, that can enter into the decision as to what kind of surgery they might have. They might choose more extensive surgery on that side, like a mastectomy, or even bilateral mastectomy as a treatment for their disease to avoid getting a second cancer in the future. So Kristen talked about those NCCN guidelines, and I think that that's just great advice to get a copy of those NCCN guidelines updated really every 3 months and carry them with you to all of your clinicians. I imagine that the majority of you have found centers that understand PTEN and subspecialists that are comfortable in its treatment. But there's a lot of education that we all need to do with a lot of providers. So I think that I applaud many of you for teaching a lot of the medical professionals that you visit about this disorder and its associated conditions. So with regard to breast care, patients are advised to begin what we call breast awareness starting at the age of 18. We used to recommend formal breast self-examination. Breast awareness really just is that, becoming comfortable with your breast tissue and reporting any changes to your health provider. At the age of 25, we begin examining patients every 6 months, a clinical breast examination. And oftentimes, I actually see patients earlier than 25 because patients with PTEN will have what we call those fibrocystic breast changes, the lumpy, bumpy tissue that can form discrete lumps, or even benign lumps like fibroadenomas are very common as well. So I'll often follow younger patients, but we don't really begin screening until the age of 30, or 10 years earlier than the first affected relative in the family, the first person who has had breast cancer in the family. And since, as many of the scientists have talked about, the de novo rate of PTEN mutations is so high, meaning that it starts with that individual in a family, we often don't have family history. It's not like patients with BRCA mutations where they've seen a lot of disease in their family. You've seen mothers, sisters, aunts go through things. A lot of times with PTEN, it's hard to identify with these risks because as a first person who's affected in your family, you may not have any family history of these diseases. So that's important to keep in mind. At the age of 30, we embark on MRI screening, which is the most sensitive way to catch things early, alternating with mammography. And the reason why we still do mammograms, even when we're doing MRI, is that it's the only test that can identify breast calcifications, microcalcifications, which might be the earliest form of disease. And also, architectural distortion is another thing that's only seen on mammogram. And so, in the new NCCN guidelines this year, they've entered to consider breast tomosynthesis in place of your mammogram. And that's actually important for all women, whether you're affected by PTEN or not. If you have dense breast tissue, which is very common in young women, and actually in women across the board, 47% of women have dense breast tissue, that new three-dimensional mammogram or the digital breast tomosynthesis might be a better choice for you. And finally, patients with PTEN are encouraged to talk to their medical providers about risk-reducing mastectomy. And we use the word consider, and that's because our breast screening is really good at catching things early. And so the mastectomy is in no means a recommendation, but it's a consideration, and it's something that we're here for you if you're interested in discussing. But you certainly can choose breast screening as a way of catching things early. Why do we use MRI? Because it catches things earlier than the mammogram typically. This is a study that was done in patients with BRCA mutations showing that with MRI, patients were more likely to be caught with that intraductal form of breast cancer, DCIS, before it becomes invasive. And patients were more likely to have node-negative cancers that were smaller and hadn't spread to the lymph nodes yet if they were MRI detected. And we've looked retrospectively at the high-risk patients at Cleveland Clinic and certainly found that to be the case, that in patients who undergo those regular MRI screens, if cancer develops, it's likely to be caught very early. This is a slide that shows about the breast density. There's 4 categories of breast density, ranging from entirely fatty on the left to really, really dense on the right. And again, 47% of us have dense tissue, either one of those last 2 categories, heterogeneously dense or extremely dense. And the 3D mammogram, rather than the standard 2 views, an arm kind of comes around and takes a series of projections, and we're able to digitally recreate a 3-dimensional image and scroll through the tissue. So it's a better test for those with dense tissue. There's 25 to 40% improved cancer detection and 15% fewer callbacks. There's not specific data for either MRI or a digital breast tomosynthesis in PTEN carriers because it's just too early. So we do talk about the risk-reducing mastectomy, and Dr. Stephen Grobmeyer is here with us today, our head of breast surgery, and can answer more specific questions. But generally, it can reduce your risk for the development of breast cancer by at least 90%. And this is a photo of a woman who's actually undergone the procedure at Cleveland Clinic. We're often able to do nipple-sparing mastectomy, saving the nipple and areolar complex, and doing reconstructions that are very cosmetically acceptable to many women. So, Dr. Eng has taught us that, if we identify patients early, embark on appropriate screening protocols, we can catch things early and sometimes prevent things altogether. In this day and age, perhaps Rachel Cowden would not have died of breast cancer that young. So we believe, in conclusion, that all women deserve to receive the information needed to allow themselves to make decisions that they believe are in their best interests. And I am looking forward to also hearing Dr. Karen Hurley's perspective about the emotional and psychologic components of risk and risk management. thanks so much, and I'll be back after her talk to answer any questions. Thanks.
All right, Dr. Karen Hurley joined the Cleveland Clinic in 2016, bringing with her almost 20 years of experience as a licensed clinical psychologist, specializing in hereditary cancer risk. She received her undergraduate degree from Bryn Mawr College in 1983 and completed her PhD in clinical psychology at Temple University in 1998. After finishing a postdoctoral fellowship in cancer prevention and control at the Mount Sinai School of Medicine in New York City, she spent 8 years on faculty at Memorial Sloan Kettering Cancer Clinic, conducting research funded by the National Cancer Institute. She spent another 6 years in private practice in Manhattan and taught graduate health psychology at Teachers College and Columbia University. She has provided psychotherapy and consultation to approximately 500 individuals, couples, families with BRCA1, BRCA2 mutations, Lynch syndrome, FAP, hereditary diffuse gastric cancer, and other forms of hereditary cancer. Please welcome Dr. Hurley. Decisions one?
Yes. Yep, that's me. Okay, great. So thank you so much for having me. It really is a privilege to be at the Cleveland Clinic and to work in close cooperation with the physicians to help patients take the medical information, process it, and really make it yours, to figure out what all of these facts and figures, all of this research, how does that boil down? What happens when you go home and have to think about what this means for you? So one of the questions that we get when someone is presented with a choice such as having both breasts removed to reduce cancer risk is, can't you just tell me what to do? Right? So we want to think about why that, why, even though that seems like a logical question, what happens is if you follow what a physician just tells you without making it yours, is that you may not think through all of the implications, and you may not process all of those emotions, different feelings that you have about having to go through this procedure. So therefore, if you rush too quickly to the decision, it sets you up for the possibility of regret later. Also, the process of going through the decision, of going online, doing the research, talking to people, thinking about how does this feel, you start to get used to the idea, and it starts to give you coping strategies so that if you do move forward, or no matter what you do, whether it's surgery or screening, that you have the coping strategies that you're going to need to get through this, to go through all of the ups and downs of your choice. So, but if you, say for example, you go ahead to surgery without really processing it fully, and then maybe you're one of the unfortunate ones who has an infection, or your surgery doesn't look, your reconstruction doesn't look as good as the one that was in the photo, then it's going to undermine your ability to trust your doctors in the future, that doctor and other ones, because with PTEN, this is really a lifetime relationship that you have with a team of physicians. So to make a big decision like whether or not to have a mastectomy means that, if you're really going to take the time to process it, there's going to be an uncomfortable period where you're not sure what you're going to do yet. And we don't like being uncertain. We like feeling empowered. We like feeling like we're moving forward. So hanging in that place until the decision is made means being able to tolerate a certain amount of anxiety and discomfort. And sometimes what will happen is people will say, well, how will I know that the decision, when I know what's right for me? people who have, once they've made their decision, will describe that there's kind of a pivotal moment where it changes. So, you know, like if you're cooking and you're making a sauce that has flour in it and you're stirring it and it's kind of liquidy and you're wondering, is this ever going to turn into a cream sauce? And then it just kind of converts over. There's that one moment. And that's kind of what happens with the decision. If you spend enough time stirring it in your mind, that moment of changeover happens, and then things start to fall into place. So let's talk a little bit about what that stirring process actually means. One of the things I think that, you know, if we step back for a second about what you're asked to do when you're thinking about one of these big surgeries, is that it's a different way of thinking about your body. You know, we like to think of our bodies as a whole, as a unit, as interacting, but you're talking about a surgeon sort of acting upon you as an object. And if you think about it, when they start talking about all the different reconstruction options, you know, we're going to remove your breast, we're going to take tissue here, we're going to move it there. We're not made out of Legos, right? So there's a certain amount of kind of taking apart and putting back together mentally that has to happen in order to be able to appreciate what this option is going to mean for you. Another thing that, you know, again, if we step back a little bit, you know, these choices, you know, it's amazing that we do have these options. And as Dr. Pederson pointed out so well, without, you know, that Rachel Cowden might be alive today with some of these choices, but they're still pretty drastic, right? These are things that no one would want to have to do if they had to. Going to have a mammogram or an MRI every 6 months, or having such a big surgery. So, you know, 200 years ago, when you had a health problem, people put leeches all over you, right? We don't do that anymore. And with all the research that is happening with PTEN, someday what we are offering now will look as primitive and ill-informed, right? So, but we're not there in that future, we're here now. And if you're facing risk, you're in that position of needing to think about what do you want to do about your risk now, and not in that imagined future. So being able to make peace with that is part of the decision process. So when I talk about a process, then what I mean is that the decision happens on 3 levels. There is taking in all of this information, which is one of the things that we're doing today, and there's a lot of information to process. There's also the emotional level. What does it feel like to have to make this decision, right? How does it fit into your life plans? How does it fit into how your whole family is doing? And then there's also the action level, which is once you've put the pieces together, they're still actually taking that next step, picking up the phone and making the appointment, showing up, you know, at that day of surgery, right? So feeling like that you're able to do that, that you have the coping skills and the support to carry it out, is a part of the decision process itself. So when I meet with someone who is thinking about whether or not she wants to have a bilateral mastectomy, this is kind of the checklist I go through to see, you know, how the decision process is going. First of all, I do ask, have you seen pictures? Right? So that, you know, do you have like a realistic idea about what things will look and feel like afterwards? Having a realistic idea about, you know, what will happen after surgery. There are unfortunate times when there are complications. Sometimes people need more than one surgery to get things to, you know, sort of look and feel okay. So this is not a quick fix. It's not like you wake up with new perky breasts and everything's going to be fine, right? Sometimes I've had patients where the reconstruction process takes as long as a year. And so it's important to, you know, incorporate that's a possibility, even though that might not be your experience. The breast, a reconstructed breast doesn't feel the same, right? And it doesn't respond the same way sexually. So women vary a lot in how a breast feels during sex. Some women are very sensitive in that area, and some not very much. Sometimes when you're having that sexual response, having a warm glow through the body, then this becomes like a blank zone, and that's weird, right? So you want to think about, there are trade-offs in terms of what you're giving up versus what you're gaining in terms of reducing your risk. And then also it's important to think about what's important to you as a person. What are the things in your life that makes your life good? It gives you a good quality of life. I saw a woman recently who was thinking, she was really gung-ho about surgery. She said, I want to live, I'm going to have this bilateral mastectomy. I got her to talk a little bit about, what do you do for fun? Talk about your family. They go on backpacking trips every year. And they do mountain climbing. It's a very active family, water skiing, and this is how they bond. And I said, has anyone talked to you about how the musculature through here is going to change a little bit? You might have some activity restrictions. And all of a sudden, I could see her face change as she started to take in, what am I trading away? All that precious family time. So does this picture look familiar to anybody? Right? This is in the information age, going online and being inundated with information, but also horror stories, complaining, right? All the different things that can go wrong. It can really be an information overload. So I really encourage people to practice information hygiene when you're in this processing phase. So one way to do that is to say, what's that one thing, next thing you need to know? Go online, look for it, and then stop. Back away from the computer, right? Another thing, and this is really a crucial point, is that when you're making a big decision like having a bilateral mastectomy, it requires that you think about your priorities, what's going to be right for you, putting the focus on yourself. Now, we vary in the extent to which we are